Good morning, colleagues. Good day, colleagues from the Americas. I'm Rosa Sandoval and a coordinator in PAHO. Welcome to our webinar on tobacco control and better care for NCDs, key aspects for for services to help tobacco cessation. I see we already have 226 of you who have joined us. Thank you to all of those who have greeted us in the chat box. We have people from Peru, Paraguay, Brazil, Cuba, Argentina, Uruguay. Welcome to this seminar. This is the fourth webinar in a series of 5 educational seminars on a learning pathway for the initiative to provide better care for NCDs. It's a certifiable webinar, which is organized by the Pan American Health Organization to strengthen technical capacities in healthcare teams in primary healthcare. We seek to provide brief, accessible, and updated training and to promote the exchange of experiences, interprofessional work at a community level, and we hope to implement this effectively in our initiative across the region. This webinar will last 90 minutes. It will be recorded, and we have simultaneous interpretation in English, Spanish, and Portuguese. You can have a little look at the globe at the bottom of your screen, and you're able to choose which language you would like to listen to today. In the chat box, we are also going to be sharing with you some logistical issues throughout the session and things that have to do with this webinar cycle. If you have any questions, as we are doing our presentations, I would invite you to put your questions into the chat box, into the question and answer chat box, please. And you'll see that at the bottom of your screen. And then we will have some time at the end to be able to ask these questions to the speakers. I would also like to share with you the objectives of this session today. First of all, we want to give a general overview about tobacco control as an essential strategy to prevent and manage NCDs. We also want to present the role of tobacco as a key measure in controlling tobacco, and this is key to controlling NCDs. We also want to look at best practices and effective interventions for tobacco cessation. And we are going to be hearing from a colleague from the WHO with us today. And we will be looking in detail at tobacco cessation with healthcare teams in primary healthcare. So I see we're now 263 participants, and this includes healthcare professionals who work in primary healthcare. We have members of interprofessional teams in primary healthcare across our region. We also have decision makers at the policy level in primary healthcare and those that work in the area of NCDs in general. So now I would like to give the floor to Vanessa Garcia, who is the head of the Department of NCDs and Mental Health, and she is going to be opening this session for us. Thank you very much, Rosa.
Hello, everyone.
Hello.
Thank you all for joining us today. On behalf of the Department of Non-Communicable Diseases and Mental Health and the Risk Factors and Nutrition Unit at the Pan American Health Organization, it is my absolute pleasure to welcome you all to this regional webinar on tobacco control and better care for NCDs, key aspects for providing tobacco cessation services. This webinar is part of the training itinerary of the Better Care for NCDs initiative to accelerate actions in primary healthcare. As we all know, non-communicable diseases remain the leading cause of death and disability in the region of the Americas. Tobacco use continues to be one of the main risk factors for NCDs. Each year, it is responsible for more than 7 million deaths worldwide, including 1.6 million people who are exposed to secondhand smoke. In the region of the Americas, tobacco use accounts for 11% of deaths for cardiovascular diseases, 17% from cancer, and 34% from chronic obstructive pulmonary disease. and it is also an independent risk factor for other NCDs. These figures remind us that reducing tobacco use is essential for improving population health and achieving the Sustainable Development Goals. Through the Better Care for NCDs initiative, the Pan American Health Organization seeks to accelerate the integration of comprehensive, evidence-based, and sustainable services into primary healthcare. Tobacco cessation is a fundamental component of this effort. It is not only highly cost-effective, but also a deeply ethical response that enables people to live longer and healthier lives. Today's session brings together specialists and experts who will share updated WHO recommendations, as well as regional progress on tobacco cessation. We will also hear about practical approaches highlighting the role of primary healthcare in strengthening and supporting countries to expand cessation services and tobacco control. We do hope that this exchange will consolidate our collective efforts to make tobacco cessation a standard component of primary healthcare throughout the Americas. So thank you all again for being part of this session, and I look forward to hearing all the comments and inputs we are going to have today. Thank you.
Muchas gracias, Vanessa, por acompañarnos el día de hoy y por
Thank you so much, Vanessa, for being with us today and for your words of welcome. So I would now like to give a very short presentation to contextualize this issue of tobacco control. And I want to show how it fits in with this Better Care for NCDs initiative. Thank you very much for sharing my slides, and we're going to go on to the first one. The tobacco epidemic. So these presentations, these PowerPoints are going to be shared with all of you, so you'll be able to look at the numbers that Vanessa shared. You can see that the numbers of people who use tobacco in our region and what this means in terms of mortality, morbidity, and the economic cost that's associated with this disease burden. But I'd like to leave you with one key message here, which is that tobacco is the common risk factor for the 4 main NCDs in our region. And here you can see these figures and how they traduce into mortality and morbidity. Let's go to the next slide, please. So, what is happening with the tobacco epidemic in our region? I'm going to end these slides with the good news regarding this, and you're going to see that tobacco prevalence in the region, which there's also good news at a global level on this, because there's a declining trend. But there are 2 issues that concern us. The first is that I'd like you to have a look at 2 of the graphs on the screen, the ones to the left, and you're going to see the standardized prevalence in adults and then in youth. So when we say youth, we're talking about young people from between the ages of 13 and 15 years old. So these are very young people to be consuming addictive products. So what conclusion can we take from this? What can we learn from the 2 graphs to the left? So the first thing is that when we compare men and women, adults, if you look at the blue and the red, you will see that prevalence in adults over 15 years of age is in most of the countries, if not in all, prevalent in men rather than women. So there's a significant difference between men and women in terms of tobacco use. However, when we talk about young people, that's where we realize that that difference does not exist. So between young men and young women, between 13 and 15 years of age, we see that there is no difference, and there are even some countries where girls consume more than boys. So that's the first message. And this is what we call the feminization of tobacco consumption in the Americas, because prevalence in these young people from 13 to 15 years of age gives us a view of what's happening in the future. And the second key message is that the use of e-cigarettes is growing at an alarming rate. We're going to be sharing with you a communiqué from the WHO regarding this alarming trend, but we can see that there is a huge growth in e-cigarette use in the countries of our region. And this was a trend that we saw across many countries of our region in Latin America. So, what should we do about this tobacco epidemic? Thankfully, we have the answer. We know what we have to do. The first thing is that we have the global mandate, which has been put together in the Framework Convention for Tobacco Control, which was published in 2003 and passed in 2005. It's an international law, and it's an international treaty that was made by the United Nations, and it means that the countries that have ratified it are legally bound by its mandates. So from a technical point of view, we would highlight 6 interventions which are included in this framework. You can see it here. It's the technical package known as Empower. And in the WHO, we launched this in 2007. So we can see that this includes more cost-effective measures within the Framework Convention on Tobacco Control. So as I showed you on the previous slide, we see that there has been an effort to monitor tobacco use by the national authorities, and our job is to try to standardize this. So we can see that this was laid out in Article 20 of the Framework Convention on Tobacco Control, for those that aren't familiar with it. So we also want to try to protect against exposure to tobacco smoke. This is laid out in Article 8 of the Convention, and it includes a total ban on smoking in public places and in indoor areas, closed areas. So then we have the O of Empower, and that has to do with offering services to help people to stop smoking. We're going to be talking about how this is being implemented in the region of the Americas. Then we have W, which in English stands for warn. And this has to do with warning the population about the damage that can be caused by tobacco using big visual displays on packaging. And we can see that we have made a lot of progress in this area. And I told you before that this treaty became international law in 2025 of February. So we have had this global consensus regarding how to tackle the tobacco epidemic for 20 years. It's a legally binding international instrument. Then we have enforce, which has to do with enforcing the bans on tobacco, advertising, promotion, and sponsorship. And it targets marketing strategies targeting youth. This is very important, especially in light of the issue of the feminization of the tobacco epidemic. So we know that one of the strategies of the tobacco industry in our region in particular is to direct their marketing campaigns to the young female population. And this is something that we're seeing. So when it has to do with promotion and sponsorship and advertising, whether it has to do with traditional cigarettes or e-cigarettes, this is very relevant. And then finally, we have our raised taxes on tobacco products to reduce affordability and consumption.
Now, what we can see here is a series of legal and international instruments like such as the CMCT to tackle this epidemic. We will also share with you our strategy and action plan to control tobacco control in the Americas for 2025 till 2030 that was ratified by our member states last year in our steering committee. We also have a series of instruments that gather these measures, and they are global instruments that have to do with NCDs, such as the World Prevention Plan or the Sustainable Health Agenda for the Americas. As I know that there's great concern, legitimate concern about how e-cigarettes consumption is increasing, we will also share the decisions of the Conference of the Parties on these issues and how to tackle them so that you know everything about these issues. Regarding e-cigarettes, this requires the same amount of effort and the same interventions to tackle other tobacco-derived products, such as preventing the publicity and promotion of these products. The industry is trying to hook young people. We have to prohibit their use in public spaces because emissions can affect other people, and we need to keep on advancing on these prohibitions because smoking in these places undermines all of the efforts that we made to tackle this problem. We know how to tackle this problem. We have experience in this, and this is shared in the mandates. Next slide, please. Here we can see an overview of how we've implemented the Empower package in the Americas. What you can see here in this color-coded graph is, well, as you know, the MPOWER, as we have just said. What we can see here is how we have slowly increased the numbers that you see here in the region. The numbers represent the countries that are implementing the Empower measure package. And here you have a photo. The other one was like a snapshot, but here you can see how each country in the region of the Americas has been implementing this regulation package to promote tobacco cessation so that users can stop smoking and prevent youth from initiating in this habit. We need to prevent children from becoming addicted to a highly dangerous product, and we also need to help those who are engaging in the habit to break the habit for once and for all. We can see the 6 policies that we've just mentioned. If it's in green, it means that it's implemented exactly how it is stated in the FCTC. We see that there are countries in the Americas that have different measures implemented. We know that many of the countries that are joining us today can already enjoy these best practices applied in their countries, and you can also see the year in which these practices were approved by each country. I want to mention that the protection of tobacco smoke is a measure that not only helps protecting others, but also we know that it helps smokers to stop smoking, because if they cannot smoke in public places, then that works as an incentive, because it helps those who are trying to quit smoking to enjoy a place in which their effort to quit smoking is encouraged rather than hindered. Something that's very, very important to note as a benefit of these policies is that it denormalizes smoking, because nowadays children are growing up in an environment where they're told that tobacco cannot be consumed in a public space because it is hazardous. So that creates a very clear message for them. And this also includes e-cigarettes. They have to be included in these laws so that our efforts are not undermined. I want to highlight the O, which, as I have said, on the P, actually, the prohibition of these promotion measurements, because we need to enforce this to have a regulatory framework that really encourages people to make wise and healthy decisions. Regulatory frameworks aim towards making the healthy choice the easy choice. So we cannot expect a teenager or a child to resist to the promotion of a product if this product is being given freely outside of their school, or if they go to a sports event, or if you can smoke anywhere and the product in the packaging does not contain a warning of how dangerous it can be. We want to reverse this situation, and we will talk about how we can articulate all of these next steps in the first line of primary healthcare, how we can help people getting to these places thanks to this framework. We want to use it as our tool and work hand by hand with it. Next slide, please. Here we have an overview of the region. Please take a look at the right side of your screen. You can see the map of the Americas in 2003. As I was saying, green means that the policy has been implemented as per our FCTC, and the red color means it hasn't been implemented. In 2003, it was also the year in which I started working at PAHO, but if that year I had to show you how the Empower package looked like, I would have had to show you 3 red maps, both for prohibitions, for inclusion of health warnings, and also for the prohibition of tobacco advertising, promotion, and sponsorship. As I said, we have 24 countries that have implemented these measures, and they look very, very green. Actually, in 2020, we celebrated South America having the first sub-region in the world being 100% smoke-free, having laws that prohibit smoking as per the FCTC. So we do have important progress, but there's still a lot to be done, especially when it has to do with the prohibition of advertising, promotion, and sponsorship. We want to protect youths from misinformation and disinformation on this issue. I told you I was going to give you good news. It is half good news. It's on the left side. It's about the trend of the prevalence in tobacco consumption. We are on the right track. However, we need to increase our initiatives, and also we need to focus on the consumption of e-cigarettes. This is my final message for you right now, which is that the industry of these products try to place e-cigarettes as a quote-unquote damage control product or as a solution to the tobacco epidemic. However, I want you to zoom in on this graph. These nicotine products are not being promoted to adults that are already consuming tobacco and nicotine products. On the contrary, they're being promoted to young people. Why? So that they can initiate in the consumption of a product that is highly addictive. So if we really wanted to help end this tobacco epidemic and this tobacco and nicotine products, we wouldn't be promoting products such as this one to young people as these industries have been doing. So we have to be very alert and careful because this damage control narrative is not the right narrative, because as I said, at a population level, these products are being used more by young people, and even adults are using it as a dual consumption. So this is contributing to this narrative that the industry is trying to get across. Next slide. Okay. Thank you very much for your attention, and now I'd like to give the floor to Adriana Vacelar, specialist in tobacco vigilance and focal points of tobacco cessation of our regional tobacco control team, to give her presentation on the outlook of tobacco cessation in our region. Adriana, the floor is yours. Thank you very much, Rosa. Can you see my screen? Yes, okay. Thank you very much. Good morning, everyone. It's a pleasure to be here today, and today we're going to look at the outlook of tobacco cessation in the region. So, to begin, I'd like to tell you that according to the estimations for 2024, 14% of the Americas populations that is 15 age or older consume some sort of tobacco product, 18.9% of men and 9.1% are female, just as Rosa has highlighted. in her presentation. This means that in our region we have about 115 million tobacco users, out of which 110 million consume manufactured cigarettes, among the most consumed products. Tobacco control includes several measures and interventions that contribute to protecting those who do not consume tobacco and also to help those who do and help them quit. And that's what we call cessation. The measures favor or encourage people to stop smoking and stop consuming tobacco, and it includes treatment to tobacco dependency, and it is among the most cost-effective interventions recognized by PAHO to reduce NCDs. The offer for cessation is one of the interventions that are also part of the FCTC. I'm not going to talk about FCTC, the Framework Treaty, but I do want to mention that we have several articles that have to do with reducing demand and supply of tobacco. Article 14 is among these series of measures, and it has to do specifically about the dependence and cessation of tobacco. This article determines that each party will take necessary measures based on evidence and best practices to promote users to quit smoking and abandon their dependency to smoking. The PAHO made a series of recommendations on how to implement this article, which are: tobacco is highly addictive. We have nicotine, which is the substance that causes this addiction. Cessation measurements have to be applied in synergy with other tobacco control measures. The treatment of dependency has to be accessible, affordable, and inclusive, and healthcare and primary healthcare systems play a key role in promoting support so that these people can break their habit, and follow-up and evaluation are fundamental, and the support has to be done actively, hand in hand with civil society. These are the considerations to adopt this article. Among the recommended actions we have: tackle tobacco consumption by healthcare professionals and other people in tobacco cessation, because that is a behavior model that can help reducing the social consumption of tobacco. We need to develop the training capacity of healthcare professionals so that they are ready to make the necessary steps to deal with treatment. We need to use the systems and resources available to guarantee the greatest access possible to this treatment so that everyone can receive early intervention. The registration of tobacco consumption in medical records has to be mandatory. Moreover, we need to guarantee that services are protected of commercial interests of the tobacco industry, and we need to promote these efforts as collaborative measures.
As we mentioned in the previous presentation, in 2008, the WHO launched Empower to help countries to reduce tobacco consumption, and this includes 6 measures which are accessible for clinical management of tobacco dependence in primary health care, and it provides community resources and includes material for healthcare workers, for doctors, and the support provided through quit lines and community programs also includes the different type of behavioral therapies. So each 2 years, the regional offices of the WHO monitors how the states are implementing the Empower measurements, and they publish a global report on the tobacco epidemic. And I will share this with you in the chat of this webinar. We only have a version of this in English. We don't have translation of it in Spanish, unfortunately. But you can assess 3 related components, which are characterized as best practices. The first component is the availability of support services to help quit smoking, total or partial coverages in networks, which might include primary healthcare in hospitals, in communities, or in other healthcare services. Free quit lines to help people quit smoking, and brief advice, intensive brief advice. We're not able to measure this, but we try to find the availability of these digital services based on text messages and digital modalities for tobacco cessation, such as smartphone applications, online interventions based on AI, and these increase the probability of helping people to be successful in their efforts to stop smoking. And finally, the last component is to offer therapy, which might involve nicotine patches or gum. So how are we doing in the region currently? To the right, we have a map that Rosa showed us. And we can see that there are only 7 countries in green: Mexico, Canada, the United States, Brazil, Costa Rica, and El Salvador are the countries which comply with all components of the best practices. That's to say, they have the quit lines, they have nicotine replacement therapy, and the community services that we mentioned. Then we have 15 countries in yellow and 2 countries in Central America. And then here we see it's 6 countries in South America. There are some in the Caribbean, and there are no countries in Central America. They do have support services, nicotine replacement therapy, but the patient or user has to pay for this. The costs are not covered by the healthcare system. And finally, we have 7 countries here in South America. There's 1 in Central America and some in the Caribbean, in which none of these components are established. And to the left, in this graph, we see each one of the components in the total of the countries, which have some of the criteria for the best practices. So there are 14 countries in the region that have a quit line, 20 countries that have nicotine replacement therapy. However, only 13 countries offer these products at a low or no cost for the patients. And some of these services are offered in hospitals and other in primary healthcare. Some of them are offered in the community and others are offered in other healthcare services. So, to conclude, we still have a long way to go. According to the WHO, 60% of people who use tobacco would like to leave, but only 30% are successful and have access to the necessary tools. Every person who wants to quit smoking and receive support is much more likely to be successful if they receive support. However, it is important that costs are covered, especially for populations in low-income areas. It's also important to strengthen the comprehensive support with these best by interventions of the WHO. Progress in control measures for tobacco in countries is increased when we have brief advice that's offered and when we're able to offer systems which offer support services, brief advice, for example, in primary healthcare and hospitals, quit lines, free services, digital services, and specialized services for treating dependence. And this also includes behavioral therapy and medication. Here I will show you some of the resources that we have available for professionals, and I would invite you to get to know these and to share them. Thank you very much. That's all I had to present today. Thank you very much, Adriana. And thank you very much to the participants who are asking questions, and we have been answering them in the Q&A box. And now
I'll switch to English to introduce my WHO colleague, Don Bofu. He is a medical officer from the No Tobacco Unit at the Department of Health Promotion in WHO headquarters in Geneva. And he's going to present to us the WHO clinical treatment guidelines for tobacco cessation in adults. Dombo, the floor is yours.
Okay, thank you, Rosa, for your nice introduction, and good morning, everyone. So it's my great pleasure to be part of this very successful webinar. I just see we have more than 430 people participating. That's amazing. So I will use around 10 minutes to really introduce WHO clinical treatment guideline for tobacco cessation in adults. I'll start with explain what's the guideline development process and methods we used when we developed WHO guideline, and then what's the objective of this guideline. And I will use my main presentation focus on give a summarize in terms of what are the guideline recommendations. So start with the guideline development process and the methods. The guideline that was released on the 2nd July 2024 actually is the WHO's first ever clinical treatment guideline for tobacco cessation in adults. So as a WHO guideline, it has followed WHO's standard process. You can find more details in WHO handbook for guideline development. The guideline development, we have a technical department which is WHO Department of Health Promotion, oversaw the guideline development process with a dedicated WHO steering group and methodologist, and also a guideline development group. Experts from this region, from PAHO region, contributed to the guideline development. There are several experts contributed to that. For example, Adriana Basela, she served as a member of WHO steering group. Edward and Vazan, they actually joined the WHO guideline development group to contribute to the guideline development. So I just want to take this opportunity to thank all of them for their great contribution to this guideline development. WHO Guidelines Review Committee monitors the guideline development process to ensure WHO regulations standards are applied. So that's the guideline development process and methods. The purpose of this guideline is to provide a comprehensive set of global technical guidance for WHO member states to support 1.25 billion adult tobacco users to quit by using evidence-based behavior interventions and the pharmacological interventions as part of a comprehensive tobacco control approach. So this guideline contains 12 recommendations for 7 categories of interventions. So I'm going to go through each of them in more detail. So let's first look at the first category. That's the behavior support in clinical and community settings. I think this probably is the are the recommendations most relevant to today's webinar. So here, the behavior support we define as support other than medications aimed at helping people stop their tobacco use by improving their knowledge, skills, and strategies. It includes brief advice and also intensive behavior support, which are multiple sessions of individual, group, or telephone counseling. So in this category, the guideline has two recommendations. First, WHO recommends brief-wise between 30 seconds and 3 minutes per encounter be consistently provided by healthcare professionals as a routine practice to all tobacco users assessing any healthcare settings. In other words, brief-wise has been recommended as an intervention which should be every healthcare provider's business and should be given to all tobacco users, either interested in quitting or not. They should be provided brief-wise. The second recommendation is for the intensive behavior support. WHO recommends more intensive behavior support should be offered to all tobacco users who are interested in quitting. Multiple behavior support options, including individual face-to-face counseling, group face-to-face counseling, or telephone counseling, should be provided. These are two recommendations for the behavior support in clinical and community settings. The second category is the digital tobacco cessation intervention. WHO recommends digital tobacco cessation modalities, which include 4 of them: text messaging, smartphone applications, artificial intelligence-based interventions, or internet-based interventions, individually or combined, can be made available for tobacco users interested in quitting, either as an adjunct to other proven tobacco cessation support or as a standalone self-management tool. These are recommendations for the second category. For the third category, that are pharmacological interventions. WHO guideline contains 2 recommendations for pharmacological interventions. First, WHO recommends varenicline, nicotine replacement therapy, we call NRT, bupropion, and cytisine as pharmacological treatment options for tobacco users who smoke and are interested in quitting. Among them, varenicline, NRT, or bupropion are recommended as first-line options. For those who are interested in using NRT to stop using tobacco, WHO recommends combination NRT over NRT monotherapy. The second recommendation is really for those who maybe have an inadequate response to the first-line treatments. For those tobacco users, WHO recommends bupropion in combination with NRT or varenicline may be offered to them who are interested in quitting when they don't have inadequate response to the first-line treatment. These are the recommendations for the pharmacological intervention. Let's look at the fourth category, that are intervention for smokeless tobacco use cessation. For smokeless tobacco users, WHO recommends providing more intensive behavior support interventions, which we just mentioned: individual face-to-face counseling, face-to-face group counseling, or telephone counseling for them to quit. WHO also recommends varenicline or NRT as pharmacological options for smokeless tobacco users who are interested in quitting. In terms of a combination of behavior and the pharmacological treatments, WHO recommends we should always combine pharmacological therapy with behavior intervention to support tobacco users who are interested in quitting. For the traditional, complementary, and alternative therapies, the guideline development group has not made any recommendation, but they have given a statement because evidence is insufficient to make a recommendation for or against traditional, complementary, and alternative therapy for tobacco users who are interested in quitting. If these therapies are utilized by tobacco users interested in quitting, we need to make sure they are also offered other proven tobacco cessation interventions, for example, the behavior support and pharmacotherapy. So they need to receive comprehensive support. In other words, the traditional, complementary, and alternative therapy shouldn't be provided to tobacco users to quit as a standalone intervention. In terms of last category, the system-level intervention and the policies, the WHO guideline has 3 recommendations. First, WHO recommends all healthcare facilities should include in tobacco use status the use of tobacco cessation interventions in their medical records in order to facilitate the provider interaction with tobacco using patients, and also increasing the adoption and maintenance of evidence-based tobacco interventions. The second recommendation is on training. WHO recommends train all health providers on delivery of proven cessation interventions. The last recommendation is on the cost coverage of evidence-based tobacco cessation interventions. WHO recommends that evidence-based tobacco cessation interventions should be provided at no or reduced cost to all tobacco users interested in quitting, and low cost is strongly preferred over reduced cost. Okay, that's all my presentation on WHO cessation guidelines. Happy to answer any question later on. Thank you so much.
Thank you very much, Dombo. And ahora, pasándome al español, me
Now,
gustaría primero hacer un
first,
reconocimiento a los colegas
I'd
que
like
siguen
to
enviando sus preguntas. Muchas
recognize
gracias
all of
por
our
su
colleagues who are
participación
still
activa.
sending in
Y
their
quisiera
questions. Thank you
ahora,
for this active
invitar
participation.
a,
Now, I'd like to invite
a nuestro colega y amigo
our
Eduardo
colleague
Bianco
and
Igual,
friend Eduardo
quien
Bianco,
también fue miembro del grupo de elaboración
who
de
was
las
also a
17
member
medidas de la
of
OMS sobre
the
tratamiento
team
para
that
cessar el tabaco
elaborated
y
these
co-coordinador de NATI,
tobacco
a
cessation
presentar sobre la
initiatives
importancia de
at
la exploración y el desarrollo
WHO
del
to
tabaquismo
present
y
on
de
the
las
importance
enfermedades
of
no transmisibles.
tobacco
Adelante,
cessation in
Eduardo,
the
por favor.
control of NCDs. Eduardo, the floor is yours. Thank you, Rosa, for allowing me to participate in this webinar. I'll try to not repeat what my colleagues have mentioned and highlight on the importance of tobacco consumption in the control of tobacco and of NCDs. Let's first remember that tobacco is a unique product. It's highly addictive, very difficult to quit. It increases the risk of over 50 NCDs. It kills over half of chronic consumers. And there's no safe or minimal level of consumption or of exposure, and we don't even have a safe tobacco product even. As has been said, tobacco consumption is a preventable risk factor for the 5 NCDs that are included in the 5 strategy of the UN against NCDs to be added to mental conditions. I want to highlight the bidirectional nature of the work and the documentation work. We have groups that are the ones that have the highest consumption, the highest mortality, and although they want to break the habit, they're not receiving the help that they need. I'd also want to remind you that the epidemic of tobacco-linked diseases has been industrially produced. Let's take as a marker the disease that is the most greatly linked to tobacco, lung cancer. At the beginning of the 20th century, lung cancer was a clinical anomaly. It was very rare, but from mid-20th century, after the exponential consumption of tobacco, this disease has become the lead cause of death of men and women. Going back to the main NCDs, such as cardiovascular diseases and cancer, I'd like to highlight that when it comes to cancer, there's a linear relationship. The more a person smokes, the greater the risk. But when it comes to cardiovascular disease, this is not a linear relationship, but rather we see the greatest risk with a low consumption. Over 70% of the damage is produced only with 5 cigarettes. In 1999, the publication of the World Bank curbing the epidemic estimated that in 2050, if this trend was sustained, tobacco would kill 520 million people, which raised the question, what would be more efficient, preventing people from starting smoking or trying to help them quit smoking? The answer is that in 2020, we got half of young people that would initiate tobacco use to stop consuming tobacco. If we got that, 20 million deaths would have been prevented. However, if in that period we got to diminish the amount of smoker in half, we could have had prevented 340 million deaths, which really highlights the importance of tobacco cessation if we want to reduce the burden of death caused by NCDs. Tobacco cessation has immediate effects in heart rate, blood pressure, and very soon in breathing capacity. The risk of cardiovascular events is reduced at 50% in the first year, but the cancer risk needs 10 years to be reduced by half. Even after 15 years of quitting, the risk is still higher in smokers than in those who have never smoked. How can we get people to quit smoking? Dongbo already described which are the evidence-based tools that significantly increase the chances of a successful tobacco cessation. All I want to do is remind you that most cases have, apart from this consumption, a strong dependency that stems from biological factors that have to do with functional and structural changes in the brain, related with chronic exposure to nicotine, psychological and behavioral factors that have to do with a wide array of conditioning, and social factors that have to do with a strong system of beliefs that it was socially induced. In order to tackle these factors, we have three tools. For biological tools, pharmacological treatment. For psychobehavioral, cognitive and behavioral interventions. And for social factors, we have tobacco control policies. The greatest impact in tobacco cessation will be achieved only if we apply the full package. I do want to underscore, sorry, I had skipped these three little slides. I do want to underscore a series of minimal measures that all countries should implement to boost tobacco cessation. The first one, and this has already been mentioned, is to integrate the brief systematic advice in all primary healthcare systems. Second is to establish free telephone lines, ideally proactively. And number three, to facilitate the access to effective medications to quit smoking. This basic scheme is cost-effective and will significantly reduce the death burden caused by tobacco. Despite all of this evidence, in many countries, healthcare professionals are not trained in tobacco cessation. Systems do not include tobacco cessation treatments, and the necessary drugs are not provided. This means we have a lot of shortfalls still to be corrected. The problem is that these weaknesses are being taken advantage of by the tobacco industry to promote their narrative of damage control through the use of their new products. And they are investing loads of money to make an influence on healthcare professionals, academia, and political leaders so that they can support their narrative. If they succeed, they will cause irreversible damage to tobacco control measures and to NCDs, which is why the Frank Foundation, which I represent, and the FCTC and the Article 14 of the Health Ministry in Uruguay. That's why we have launched our initiative, NATI, to improve and to boost tobacco cessation and to counteract the narrative of damage control boosted by industries. For NATI, there are three main premises of this narrative. The first one is the belief that many smokers cannot or do not want to quit smoking. This is called, in English, hard smokers. But Harris, in 2022, researched this topic and actually proved that the countries where effective tobacco control policies were implemented and where prevalence diminished didn't show any hard smokers. Actually, smokers showed great motivation to quit smoking. The response to treatment was very positive. The second premise is the idea that if they cannot quit or they don't want to quit, well, then we should then offer them products that are less risky. We've heard that e-cigs was 95% safer, and then they reduced it to a third of the danger caused by normal cigarettes. This is not backed by evidence either. A meta-analysis published in 2024 that revised 107 studies showed that the risks of e-cigs was similar to fuels for cardiovascular disease, metabolic diseases, and others. And although the risk of asthma and COPD was lower, the magnitude is not the one that is usually spread. Fundamentally, the risk of dual consumption was worse than with the use of combustible cigs. We saw that the studied populations were studied, and the result is that they are not at all beneficial for public health. The last and third premise is that e-cigs are effective to quit smoking. The randomized essays or trials did show that e-cigs are superior to nicotine replacement therapy, but there was a problem. The sustained use of e-cigs was 9 times greater than with the nicotine replacement therapies, and for each person that quit smoking due to them, there was almost 3 that fell into dual consumption, which also proves that e-cigarettes as a population tool to quit smoking do not increase tobacco cessation. In conclusion, tobacco cessation is a key intervention in controlling tobacco and NCDs. It requires trained health professionals in a comprehensive framework so that they can provide accessible and affordable pharmacological treatment. We have to protect the system from the narrative of damage control that the tobacco industry is trying to come across, because otherwise we will be under great damage. Thank you.
Thank you very much, Eduardo, for your presentation. I think key messages are increasingly coming through, and I hope that all our participants are picking up on them.
I would like to invite Vasan Vasdeo from Trinidad and Tobago, family physician and tobacco cessation specialist, to present on how to integrate cessation services into primary health care. And Vasan, I see many people have already been asking questions in the Q&A, so feel free to address some of them if you would like to. And the floor is yours.
Thank you very much, Rosa. It's indeed my pleasure to be here this morning and, well, now this afternoon. So my presentation today is actually less academic and more practical. And I hope that the message left today is things that we can apply to our unique primary healthcare settings in the Americas. So we all know that primary healthcare is the front line in our fight against these NCDs. And these clinics, we don't just treat persons who use tobacco, we face the consequences, which we see through cardiovascular disease, cancer, hypertension, diabetes, and respiratory diseases. And managing NCDs without addressing tobacco is simply symptomatic treatment and will be like that repeating cycle, revolving door patient that keeps coming in with the complications of these non-communicable diseases. And this is a take-home point that I'd like to leave with everyone today. If at every interaction with our primary healthcare sectors and services, every single patient receives this brief tobacco intervention, we would have a lot more successful quit attempts. And we simply ask that it's just 30 seconds to 3 minutes to use this brief tobacco intervention of asking every single person that comes through our primary healthcare doors whether they use tobacco. So much so that our colleagues before would have spoken about making this assessment and making this a vital sign in our health records. Second to that, every person who comes in and is asked about tobacco use, we must strongly advise them in a personalized way of encouraging that person to quit. So as healthcare professionals, I have seen that when there is doubt by the primary care health worker, and that message seems ambiguous, seems unclear, we don't create that nature of urgency for that patient to quit tobacco. Similarly, we finally ask that every person who are using tobacco, we assess their willingness to quit. So this simple process takes 30 seconds. And we do not need to reinvent the wheel, especially in primary healthcare where we know resources aren't as forthcoming. We would like to just use this WHO endorsed 5A's model that is evidence-based and integrated into any primary healthcare workflow. So my practical advice here especially is to just use this simple technique at every visit, at every encounter with every patient in our primary healthcare settings. Now, for those patients who are desirous or not desirous, or even if they're unsure if they have the ability to quit tobacco use, this is where they then recommend further behavioral support, or what WHO guidelines refer to as more intensive support. And this is where motivational interview comes in, particularly for unsure and undesirous patients. And this is something that the trainings and the guidelines go in depth about the 5 R's and how we motivate our patients in primary care to move them from that pre-contemplative to that action phase. And this is where we recommend individual face-to-face, group face-to-face, and telehealth counseling. Now, this is where I strongly recommend that we be practical, because I understand the challenges in our busy clinics of then having to provide these intensive behavioral supports. I will come to that in a few slides, but generally, any person who is willing to quit or is motivated to quit smoking or tobacco use, we must offer that patient help. Because if we lose that opportunity to assist that patient, we lose a very, very vital, pivotal opportunity to move that person from tobacco dependent to tobacco free. And this is where this assisting is so, so important, because if our primary healthcare workers aren't able to assist our patients who are willing to quit, we've lost an opportunity that is very golden in reducing this complications of non-communicable diseases. And this is where, in that assisting, we ask persons to provide and set a quit date, discuss the challenges, and thereby provide the pharmacotherapy recommendations that Dr. Dongo went through. And then finally, we must follow up with this patient, and that is the arrange. And a simple phone call doubles these success rates of quit attempts. And most plans or most follow-up plans are recommended for 3 months. But this is just a pharmacotherapy. We strongly recommend following up these patients from 6 months from that quit date. So I understand everywhere in the Caribbean region that we've worked in, the challenge is the high NCD rates. We have limited resources in primary care, busy clinics, and a lot of the professionals say that it's time consuming for more intensive support. The solution, practical solution, is to move to a provider-led model. So by integrating this status, tobacco use status, at every visit, it becomes part of the routine, such as monitoring your blood pressure, your random blood sugars. And we integrate these cessation clinics into the non-communicable disease clinics. Because, for instance, I have learned that when someone is desirous of quitting smoking, and then you tell them that they have to come back the next day or go elsewhere to another region or another health center, it deters. It's a deterrent to that person because they already. So we must seize the opportunity in that very moment to have it provided the assisting and arranging for those patients. So my strong recommendation is that we move away from this concept that we need to have these specialized smoking cessation clinics that are few and far, maybe at the hospitals, maybe in secondary and tertiary care, but we bring these cessation behavioral support and pharmacological support and follow-up into the primary healthcare settings. So the same way we treat as type 2 diabetes, hypertension, and our primary healthcare system is able to immediately prescribe treatment, be it behavioral support, be it pharmacological support. This must be integrated into our primary healthcare settings. And of course, we must move away from the idea that primary healthcare especially is physician-led. We must go to this team-based care, and we have seen, particularly in Caribbean regions, where even the security officers, even the clerical staff are trained and motivated and becoming better equipped to advise patients, to motivate patients. So for instance, our attending nurses, they are the ones who can conduct the assessment, they ask and advise. And then the physicians, they assess, they assist and arrange. And even our pharmacists, our mental health workers, our dental, they all combine to form this all-inclusive and cohesive unit that in the primary care setting, every time a smoker or someone who uses tobacco comes into our primary health care clinics, they are very much met with a team that is motivated to helping them quit this deadly habit. So as I said, what has worked for us, especially in regions where we do not have, so much resources, we do not have maybe even pharmacotherapy, brief intervention works. Motivate and encourage your staff that just this 30 seconds to 3 minutes is highly effective and feasible. We hear the excuse of time, but it is not the barrier that we think it is. Capacity building is key. From our recent work in Guyana and Belize, we can tell you that healthcare workers are passionate about this. They are seeing the effects and the deadly effects of this non-communicable disease. I refer to tobacco dependence as a non-communicable disease by itself. And this train the trainer model is what is going to encourage champions in our local and primary healthcare settings, because primary healthcare usually goes down into the communities in the rural settings. And if we can get persons at that level in the community becoming champions, becoming these advocates for tobacco cessation, it builds the trust and the faith by the community members. We must leverage all our staff, as I've mentioned before, receptionists, pharmacists, nurses, bring everyone part of the team. So for instance, in Trinidad, where we launched some successful cessation clinics without pharmacotherapy, we had everyone being part of that cessation team, and they would wear their little badges and everything. There's a whole theme in primary healthcare that stop smoking, stop using tobacco. And my friends, finally, pragmatism over perfection. Too many times we have this idea that we need to create these specialist cessation clinics and we have to have all the interventions all at once. I tell you, if we can bring these things at our clinics for everyday use, just start with the brief interventions, build capacity, train your primary healthcare workers, we're then going to treat tobacco dependence the same way we treat diabetes, hypertension, dyslipidemia, and our patients are better served in their communities rather than in these satellite or having to travel long distances to access smoking cessation services. So finally, policy, we spoke about that, making this mandatory. Training, integrate tobacco cessation into all our medical healthcare professional schooling, from nursing, medical, dental, you name it. Advocate to get nicotine replacement therapies and pharmacotherapies on the national formularies that are part of the World Health Organization's essential medicines lists. And of course, we need to monitor. What gets measured gets managed. Use our health records to ask to see how much are we asking, and then we can see how successful is our work being done in quit rates. Treating tobacco dependence, I want to leave with this, is not a separate, specialized field. The World Health Organization has worked long and hard in creating this guideline. So the same way for diabetes, hypertension, primary healthcare workers are very familiar with these guidelines. We now have a guideline for tobacco disease, and we should treat it as a chronic disease in our primary healthcare settings. It is a fundamental component of a good, high-quality primary healthcare setting. And we need to integrate this into our daily practice. And finally, all primary healthcare workers should be trained and confident and competent in managing patients with tobacco dependence. Thank you, and I look forward to your questions.
Muchísimas gracias, Vasant, por esa tan inspiradora presentación. Mientras tú presentabas,
Thank you very
quiero
much for that
compartir,
inspiring
mi colega
presentation. As you were sharing with us, I want to share with you that
que
someone
con
said,
esto
great
comparte
presentation, let's do
esa
it.
frase,
And I think that the colleague that shared that has really picked up on that feeling that you transmitted about, and it's the same that we heard from Eduardo and from Dongbo, which has really left us with the clear message that how we can integrate these services into primary healthcare. And this is also going to go hand in hand with the populational policies and all the things that Eduardo was sharing with us, using the resources that Dongbo told us about. So I'm going to invite you to look at the chat, and we can look as a regional team about this issue of tobacco control. And we're going to be able to see how this virtual chorus run by the WHS is an example of this. So now we're going to talk about how to put this into practice. And I am therefore going to invite Gabriela Rojas from the Institute on Alcoholism and Drug Dependency from Costa Rica. She's going to share with us the experience from her country in terms of digital interventions for tobacco cessation. Gabriela, you have the floor.
Gabriela, estás en mute, perdona.
¿Listo?
Ahora sí.
Okay.
Gracias.
Thank you. I was telling you that it's a pleasure to be here and that we're going to be talking a little bit about the comprehensive strategy for tobacco cessation that we use in Costa Rica. I want to say that the main component of this strategy is the chatbot that's going to be aiding in this whole process, and it's an initiative from the Health Department of Costa Rica and other entities, as well as the IAFA. The idea is to reach tobacco cessation both for conventional and electronic cigarettes. Our program has had an interesting evolution. It has transformed not just for the tobacco users, but also under important technological advances. This chatbot system started in 2013, and it was created thanks to the health ministries and PAHO. And then we started sending messages spreading healthy life initiatives. Back then, it wasn't interactive, but it did work as an experimental platform to evaluate the effectiveness of digital support in tobacco cessation. It was related to nicotine in that time. From 2015 to 2020, we maintained the message line while evolving to technological advancements. We became more interactive, and nowadays we have an interactive system. We automated the process even further. At the same time, in that period, we started spreading social media educational content. In 2020, amidst the pandemic, the smart chatbot was definitely incorporated with the comprehensive web page and social media channels. Until then, the chatbot is still used under the Health Commission, and messages and other details are revised on a daily basis. In 2025, we're still going strong, developing new versions of this strategy. Next slide, please. So within our program's objectives, we have to reduce the prevalence of consumption of tobacco and, of course, the chronic diseases that are related to it, to reduce the incidence of tobacco consumption. We also want to increase the support services that have been mentioned previously as a more accessible tool for all the members of the population. Therefore, we want to break the barriers or bridge the gap to getting the help the smokers needs. We want to guarantee the sustainability and continual evaluation of the project in order to constantly evaluate its efficacy as years go by. Out of these three components, from 2020 onwards, we have the web page, a Facebook channel, and the chatbot. Next slide, please. Our web page can be found as saludmobil.go.cr, and that is an educational and support hub that helps users and healthcare professionals to log in order to get additional resources to what they have been using or what you can see if you have access to a cessation clinic. It is always evidence-based information. We want to keep it relevant and current and updated. We have also testimonies from people who have successfully broken the habit in traditional settings, and also thanks to these devices. And we also have experts' opinions. This platform perfectly complements the chatbot that we're going to be explaining further in the next slide. The chatbot is called Quit Smoking and Vaping in Spanish. It is currently a WhatsApp virtual assistant. It is free, confidential. It's available 24/7. It brings us good buy-in. It bridges the gaps of, schedules, commuting, transportation. It uses friendly language based on the tobacco cessation guidelines that guarantee the effectiveness without losing the warmth and the human touch in the charm. It has 17 days of prior preparations marked by D-Day, which is the day that the person decides to quit smoking. And these messages aim to reducing consumption and also finding triggers, calming anxiety, anxiety, and from the day that the user selects as the cessation day, we do a 90-day follow-up where the messages are also interactive, and we use other techniques to sustain abstinence. We also give advice on techniques, exercise, nutritional facts, and if the person ever has to relapse in their smoking journey, they can receive messages so that they can be brought to the right path again. These messages are also based on cessation techniques and on cognitive behavioral therapies. It's basically like having a healthcare professional at home 24/7. Let's go to the next slide, please. From the user's perspective, interested people have to send a message to the chatbot. Right now, we can see an example on the screen, and they are also asked to register with basic personal information. It is exclusive for adults, and it is under meta policies, which is why it's impossible for the bot to keep on sending messages. The person has to send a hello or any emoji or any sign so that the chatbot can continue the interaction. What are the perks of this system? We don't require a specific app or any advanced technological know-how. It is pretty elementary, completely free, and affordable, accessible. The third component of this digital strategy is our Facebook account, Quit Smoking and Vaping. This helps us to spread information about our program. We share advice, we create communities around tobacco cessation, and well, actually, at first, the chatbot was born in this platform, but once the pandemic started, this became more of a website or social media channel that we use to educate and motivate. We regularly publish graphs, information, short videos, and testimonials. As I said, they're all revised by the Commission, which has our whole technical support. And in the graphs and the artworks, we have a publicity company called Guiados. So, next slide, please. Among our achievements with the chatbot in 2021, we received recognition by PAHO because of how we innovated the expansion of these types of online cessation services. We have impressive numbers. Over 3,000 people have registered in the program. Over 2,000 have finished the program. 54% of those are men and 46% are women. They are between 35 and 44 years of age, and 25 to 34, that's the age categorization that we have. This helps us prevent diseases. And within the provinces of Costa Rica that have used this tool, we have San Jose, Arajuela, and Heredia. These are key provinces for us. And this leads to the challenges. Among the challenges we have that we need a more regular institutional commitment when it comes to funding, to update the bot, to apply technological improvements, to pay for publicities, advertisements. Not all users are familiar with the chatbot, and that's where digital literacy plays a very significant role. We need to inform all entities and all healthcare institutions and primary healthcare institutions. We need to inform them of this challenge in order to solve it. The infrastructure and the digital gap is also important. The provinces that use it are the coastal or the central provinces, whereas more coastal provinces do not have as much interaction with the bot, which is why vulnerable citizens or people that live in rural areas where connectivity is limited, or maybe they don't have cell phones, those are the populations that don't really access the chatbot. We also need to retain people because 1 out of 3 people do not finish the program despite our great numbers. We need to see why people are leaving the program. Is it a lack of interest? Is it a technological issue? We need to carry out a thorough evaluation because when users finish the program, they receive a survey that shows us their satisfaction and participation, not necessarily cessation, which means that at least 6 months or a year after, we need to evaluate how tobacco cessation was maintained and also how we can compare this program to other methods for tobacco cessation. Of course, social perception is a challenge because sometimes from primary care facilities, we need the patient's perspective or perception to change so that everyone can reach this information from primary healthcare. To conclude, the chatbot is a successful tool in our fight against tobacco. In Costa Rica, we've evolved despite the challenges, but a big challenge still remains. That is, from primary healthcare, we need to spread the word, and we need the healthcare personnel to be acquainted with it. We're making a huge effort, and all of the institutions are making a huge effort so that this resource can be active and so that people can use it as a tool. If you have any questions, I'm willing to answer. Thank you very much. Thank you, Gabriela, for sharing your experience. I think our region is very interested in learning more about these digital experiences and how they can be integrated in primary healthcare in our countries. We're now reaching the end of our webinar. Before closing, I'd like to ask Tombo, Eduardo, and Vasan if they wanted to add in, compliment. Thank you so much, everyone, for your questions in the Q&A. Thank you for turning on your cameras. I think we're going to go on for another 7 minutes. So 1 minute each if you'd like to compliment any key message before going to closure. I'll give the floor to Dongbo first.
But for me, I think this webinar actually is a really great opportunity for me. Also know in the region, we have many good best practice examples. For example, Wazan presented many of the interventions which can be done in primary care level. Even we don't have a medication available or not widely available, we can still focus on these wide reach approaches to help a large number of people to first try and then support them to make a successful quick attempt. And also we share, we also have the great example from Costa Rica. This has been, it's a pioneer country in terms of using the technology, say, different technology to help tobacco users to quit. I've just say really a great examples. Many other countries I think are following. They also have some experience which we could make explored in the future to get more country to share experience. Over to you, Rosa. Thank you so much.
Muchas gracias, Tombo. Costa Rica como país pionero y felicitaciones nuevamente a Gabriela y a todo su equipo.
Costa Rica as a pioneer team, thank you very much. Eduardo, you have 1 minute. So to all health professionals who are here with us today, I would like to remind you of your professional and ethical obligation to help people to stop smoking. This is basic and we're not doing it because we don't receive training, we don't receive the necessary preparation, and therefore we're not intervening to improve our health systems. And what's worse is that we are allowing the tobacco industry to capture this tobacco cessation narrative in terms of this harm reduction narrative. And this can cause severe damage to us in terms of tobacco control. We all have to work together across the countries in order to counteract this. Thank you very much, Eduardo. Thank you for that call to action, which I think is very necessary. Basan.
Yes, thank you, Rosa. And I want to implore with everyone in the region of the Americas that we must first do no harm. And we must ask ourselves a question, if in trying to help someone become tobacco independent, if giving them a lifelong addiction is truly a reasonable and recommended way going forward. And we must understand that this addiction, nicotine addiction, goes deeply into a very highly reward pathway, which is like the dopamine pathway. And we are fighting something that is really, really attacking the brains, the minds, and particularly the future generation. So I say, be warned, look out for these well-disguised clouds of, claims and these things, and be guided by the evidence. That's my recommendations. Thank you, everyone.
Muchas gracias, Hassan. Be guidance by the evidence. Me gustó mucho ese cierre y recordarle a todos los participantes aquí, hemos tenido casi 400.
I want to remind all of our 400 participants that the Framework Convention on Tobacco Control urges us to fight against nicotine addiction. It's part of this Framework Convention. Gabriela, over to you. This is a really important piece of work from the clinical angle. As well, I have the honor personally of being able to work on that angle, but it's not impossible. I've had the satisfaction of seeing a lot of people improve their quality of life and to begin to see really positive results, even just by reducing tobacco use. So the fight is real. We have to keep fighting. We have to work on this. But the satisfaction of managing to help people is wonderful. Thank you, Gabriela. I think that what you just said is a lesson that the Americas has taught us. Tobacco control is not impossible. So thank you very much. And to close, I'm going to give the floor to Vanessa Garcia. And with that, we will close today's event.
Thank you all very much for joining us today. It's been really inspirational to hear your comments and your presentations. Thank you to all the speakers for the excellent presentations, and to the participants for your engagement and commitment throughout today's session. My special thanks go to my colleagues from the tobacco control team, especially Rosa Sandoval, who needs no introduction, of course, Adriana Bacelar, Diana Saron, for the coordinated effort to prepare the session. The discussions today have highlighted that tobacco cessation is a cornerstone of effective tobacco control and to improve the prevention and control of NCDs. Today, we heard about the progress achieved across the region, the new WHO clinical treatment guidelines and country experiences that show how cessation services can be successfully integrated into primary health care. At the Pan American Health Organization, we reaffirm our commitment to supporting countries in strengthening their health systems, implementing effective interventions to prevent and control NCDs, including tobacco control policies, training health professionals, raising awareness among decision makers, as well as expanding access to evidence-based tobacco control intervention. This initiative is, of course, part of our shared vision of providing equitable, person-centered, and comprehensive NCD care. As my colleague Rosa mentioned at the start of the webinar today, this is the fourth in a series of 5 webinars that form part of the learning itinerary under the Better Care for NCDs initiative. The final session will take place on December the 10th. You will be able to watch the recordings of all webinars and complete the evaluation questionnaires asynchronously until February 2026. The participants who watch all 5 sessions, review the recommended reading, and complete the evaluation questionnaires will receive a 10-hour certificate of completion issued through the PAHO virtual campus. I invite you all to continue exploring the training materials and technical tools available through the PAHO virtual campus and to stay connected for the next sessions in this learning itinerary. Once again, thank you all for your participation and for your ongoing dedication to advancing tobacco control and NCD prevention. And before we close, I would also like to thank the interpreters and our administrative and IT colleagues who have worked so diligently to support the delivery of this webinar. Have a wonderful day, everyone, and see you next time.